do this okay? Make that smaller. Okay. Okay, so I wanted to talk about the nursing management of benign diseases and colorectal surgery. So I've been with the colorectal surgery team at OHSU for 4 years, and I wanted to talk a little bit about the connection that we have as a team, because I think that's important in the work that we get to do. Our team has 4 surgeons, 1 nurse practitioner, 2 registered nurses, 2 schedulers, and 3 medical assistants. And we are all, I think, very enthusiastic to be part of this team working together and very dedicated to this specific patient population. And I think that makes it the weight of the load we carry bearable, because we share in the vision and the mission in caring for these patients. So I feel very fortunate to work with this team. This is my dream job with my dream team. And so here's an overview of what we're going to talk about is the role of a care coordinator. It's a bit different than an inpatient nurse, although the theme I think is similar. And nursing management of benign disease can be broken down, in my perspective, to 3 areas: the preoperative setting, postoperative setting, and then overall symptom management. And then lastly, talking about how what the benefits of care coordination and overall we can achieve better outcomes for patients and cost efficiency for both the organization and for the patient. So here is just a little diagram of how I would describe the role of a nurse coordinator to really facilitate the partnership between the physician and the patient. So the patient comes into the clinic, meets with the physician, and often leaves the clinic, and then it's the role of the nurse to bridge that gap and continue to assess the patient and report to the physician and work together to move care forward, because it's often ever changing as we respond to how the situation changes. So in the preoperative setting, the role of nursing can be broken down into patient education and then the implementation of the care plan. So implementing the care plan involves taking the plan from the physician and assessing any barriers to care for the patient. And we can talk more about that later. Implementing the care plan involves reaching out to all the different teams that could be involved in executing the plan, coordinating preoperative appointments, gathering more data, working with the schedulers to book the OR time, and so on and so forth. With patient education, I find that this is a very big part of doing what we do, is getting the patient to buy into this plan essentially so that they will participate. There's often reluctance to participate in the care plan, which, like we were hearing about this morning, which can make it difficult to deliver the care. So another piece of just general education that I find important is trying to determine what is going to be motivating to the patient. And I find that knowledge is power for patients. So if you can educate them with how the care plan will benefit them, or how each piece of the care plan is essential to their outcome, I find that they are more likely to participate in that plan. So when a patient comes into our clinic for in the preoperative setting, the education involves optimizing their health status. So like Dr. Liu mentioned, having being optimized nutritionally is important for healing in all sorts of ways. And so this is what we teach the patient in the clinic, is to increase their protein intake. And I generally try to break that down in a way that the patient can understand why we need protein in our body, to get them to really take it seriously and get enough protein in their diet. We teach them to limit simple sugars, and we encourage them to exercise every day for 30 minutes. And then lastly, this is a photo of this protein drink that has been studied, and it's shown to decrease the risk of complications in patients. It's a high protein supplement, and our patients need to buy it out of pocket, and we instruct them that they can buy it at hospital pharmacies or online at Amazon. And especially in patients with poor nutrition, this can really support their recovery. So really, the patient education in the preoperative setting, we focus a lot on preparing for recovery, and that they can start impacting the kind of outcome they have with surgery in the preoperative setting. We also, in the notes that you'll see when you get these slides, there's a link to our clinic website that has been developed to help guide patients, to give them another resource for all of these same guidelines. And there's also a link to this specific protein supplement in the notes. The next piece of patient education that we give in the preoperative setting are a list of medications to stop before surgery. Those include aspirin, NSAIDs, fish oil, vitamin E, and then we instruct them to stop any over-the-counter herbal supplements. We also encourage them to stop smoking, and again, I find we usually connect them with resources because, tobacco is highly addictive, and often they need more support than just being educated on how important it is to stop. They need medical support to stop as well. So we connect them to those resources, but also, again, try to get them to buy in on how much and what the impact is to stop tobacco smoking on their healing. I also just give them basic details of where do you go and when do you go there, and all of the preoperative appointments, whether that is we need further imaging for the surgeons to complete their surgical plan, or they meet with our anesthesia team. They do a risk assessment, so they meet with that team. They may need ostomy marking if we think either we know for sure they are going to get a stoma or there's a possibility they're going to get a stoma. They meet with our stoma nurses for marking and education. And then we also cover extensively bowel preparation the day before surgery, because this is often a big deal for patients to get their minds around what to do. So here is just a rundown of what we tell them for the bowel prep on the day before surgery. The surgeons prescribe this bowel prep and also 2 antibiotics, neomycin and metronidazole. And then I just talk them through this, and many times during the clinic, stop and see if they have questions, ask them to do teach back to make sure they understand. So I won't go through the details of this because it's all right here, but this is what we use. The next part of the patient education in the preoperative setting is to review what recovery will look like and to manage their expectations around recovery. Sometimes people think they will see the surgeon and then be fixed, and they don't understand why 3 weeks later they're still feeling tired and run down, but the incision has healed. So I find talking about what it will look like after surgery really helps them when they get home to better gauge what's expected and what's not expected. Anxiety for a patient can be high when they are in the hospital. And so the bedside teaching that the nurses provide at discharge is not always retained. So I think starting the conversation early and often helps just foster and nurture the understanding and also the relationship that we have with our patients. Because further down the road, having that close relationship with our patients, I find helps prevent readmission later because they are in communication with us and have been educated in this is abnormal, this is not, because they don't have a frame of reference often for what's normal and what is not. So we talk about that. We talk about pain management, that they can very likely expect to be discharged home with a narcotic pain medication. It's also like Dr. Liu said, Americans don't handle pain well in general. There's a general intolerance for pain in America. So we educate them to be taking Tylenol every 6 to 8 hours, depending on their age and overall health status, and then to begin weaning from the narcotic pain medication, and also just the expectation that we are managing pain, we're not erasing pain. So to talk about the goals of pain management when they get home is also important. And then we also talk about the fact that narcotic pain medication almost certainly will cause constipation. So we give education around continuing a stool softener that they were likely given in the hospital that they have no idea about, continuing that in the post-operative setting so they don't get home and then get, experience constipation. So we have a kind of a chart of guidelines of how to escalate the bowel regimen when they get home. And then also, again, there's that encouragement to call the clinic if you have any questions at all. I also review when they're in the clinic preoperatively, these signs and symptoms of what would be a complication and what's normal. And then overall, the patient can expect to feel a little bit better every day, and that it'll be a slow journey to feeling like they are 100% back to their old selves. So I find that that's overall helpful, and I think that helps just the overall patient satisfaction of their surgical experience. This is a condensed version of what we give our patients for recovery care after anal rectal surgery. Again, these are done in the outpatient setting or in the day patient setting. So when they're receiving their bedside teaching from the discharging nurse, they are coming out of sedation or anesthesia. So they usually have no memory at all of any of these instructions. And then they get home and they have a crisis because the postoperative pain from after anal rectal surgery is pretty intense. The surgeons also tell them when they're in the clinic, this will be intense pain, the worst pain of your life. So the expectations are managed as to the best of our ability in this setting for anal rectal patients, because it really helps the recovery period go successfully. There's also a lot of predictable calls for this patient population in the postoperative setting, so I try to get ahead of that and be very clear with what they can expect. So in the notes of the slides is the full copy of the printout that we give patients, but this is the postoperative care, and often for these patients, I tell them the things that you're doing now to be comfortable to manage your symptoms are the same things that you'll do in the postoperative setting to promote healing. So those are sitz baths or warm soaks, and we talk about why those work. So again, it's education, layering education into every piece. And also, as a side note, there are many times that we have a patient in the clinic that has had so much information. So part of the education piece as a nurse is assessing, are there barriers to your understanding right now? Are you in information overload? And if that's the case, then I schedule a time to make a phone call with them to review all of this at another time so that it's retained. So that's an important piece to the education. It's not just delivering all of this. It has to be delivered in the most, with the best chance of retention. And often that takes many, many times. So again, these are the anorectal postoperative care instructions. And just because of the bowel habits in our country, this is all probably not anything new to you, but in our country, there's, I think, some dysfunction with care after bowel movements, and so it leads to other problems. So again, the full notes are below in the slides. So then the second piece, so there's the education piece to care coordination in benign diseases, and then also the implementation of the care plan. So the education piece obviously is patient facing, and I would say that the implementation is the behind the scenes. And this is often what takes up a lot of my day, is the behind the scenes work in pulling all of the teams together. It can be a little cumbersome. We don't have a system at our hospital for really clear communication or point people within different departments. You have to create those relationships individually. And it is great in the Digestive Health Center at OHSU. It's all in a part of the same clinic, much like here. So it can be much easier within the Crohn's patients or the ulcerative colitis patients to connect with the IBD team very readily and easily. But outside of that, it can be more cumbersome to connect with the plastic surgery team or urology, and that takes more work. It also can take some work if the care plan involves local care or needing to do some imaging locally. A lot of our patients live very far away and it's not practical or possible for them to come to us for imaging studies or multiple appointments. So there's a lot of work behind the scenes at making the care plan accessible and attainable for the patient. So one of those things is assessing the barriers to care, and this can be there can be many barriers to care. There are pretty frequently 2 or 3 different languages spoken amongst our most common patients. Spanish is very common. I would say Russian is common. Yeah, so that can be a huge barrier to care. It's something that we're working on. We do have a translation service within OHSU, but it just takes time. So we can send preoperative instruction and education materials to our translation services team and then get that to the patient. So that's a pretty big barrier to care. We also have the interpretive services you can use for phone calls. But barriers, that would be a big barrier to care. Geography can be a big barrier to care, like the other doctors have mentioned. Our patient population spans across the state of Oregon and into Washington, sometimes Alaska, sometimes Idaho, Montana. So getting them to our facility can be challenging and expensive, which is another barrier to care. We are a public hospital, and there are many people, many kinds of demographics of patients that need care, and with different access to resources, financial resources, or family support resources. Do they have someone to take them to the appointment? Do they have someone to care for them when they get home? Those are things that we look for, we assess, and we see how we can address them. Do we involve our social work team to provide lodging before surgery if they don't have the ability to pay for lodging? Do they need a ride from 4 hours away to come to the hospital for surgery? So that there's just many barriers, and it's our team's job to figure out what they are and do what we can to overcome them so that we can provide excellent care to everyone. Another piece of implementing the care plan, like I said, is involving the different teams. It's not uncommon to need to coordinate same day appointments with multiple different teams. And I really lean on our schedulers to help with that. And we have phenomenal schedulers. They are often the hinge to getting everything pulled together and working with the other schedulers in other departments to sequence appointments on 1 or 2 days so that care can be delivered. So again, that's with coordinating preoperative appointments. And then overall, just utilizing resources. Are we utilizing our resources well? Are we planning for how we're using the surgical block time that we're allotted? Do we need to request more time? All of those things are factors of implementing the care plan that the back office team, as I say, focus on and manage. So all of that is in the preoperative setting. And then we move on to the postoperative nursing care. Once we've gotten the patient to the operating room, when they get out of the hospital and they've been discharged home, our goal is to call the patient 24 to 48 hours after they've been discharged. And we assess their condition, how they're doing, triage any new symptoms, ask what questions and concerns they have, and then report all of this to the physician. Is this normal? Is this not normal? Do you recommend getting a scan? Do we need to get the patient back in? It's dynamic and ongoing. More education on postoperative care now that it's real for them. What has been surprising for them? What concerns do they have? It can be a big transition for patients to go from being cared for in the hospital by the inpatient team to going home. And the resources are very different. Their confidence in their own ability to take care of themselves needs to be assessed. And oftentimes it takes a couple of phone calls just to give the patient reassurance and just to make sure that they really are doing well. And then again, more education on advising the patient when to seek reassessment. Our clinic is closed on the evenings and on the weekends. So this comes into play when we get towards the weekend, or if we're talking and in communication with the patient and they're right on the verge of needing intervention or not, then it's important for them to know when this happens, you call this number and you talk to our on-call resident and get further assessment. This got a little mess off, but another thing that is reliably something that we deal with frequently is managing ileostomy output in the post-discharge setting. A lot of times inpatient, again, there's that difference between their confidence in managing their stoma inpatient versus getting home. And they don't often remember, every patient is discharged home with a measuring canister and instructions on measuring their output so that they know when to take medication and what the goals are. I mean, I look at every discharge summary and everyone is the same, but probably 50% of the patients say, I wasn't given any of that information. I have no idea. So this patient population we give extra attention to because they're probably the patient most likely to be readmitted unnecessarily, because a lot of their management can happen over the phone or coming into the clinic. So there's special attention for this patient because of their risk for dehydration. So we tell them, we review again the goal, 1,200 to 1,500 mils a day, pudding-like consistency, and those usually are things that the patient can track. So as we work with the patient, these are some oral rehydration recipes. So if it's looking like the ostomy output is high and they're showing some early signs, slight signs of dehydration, they can start with oral rehydration recipes and the medications, Imodium or Lamodal. which we'll cover next. But this is a good place to start for patients with output that is looking like it's higher. Here's what the patient is discharged home with, is this chart right here. And so that they know what to take and when to take it. And then if the Imodium is not working, the loperamide is not working, then the physician can prescribe Lamodal as well. So there's different medications, and we try to maximize, optimize those to help the output become lower. Some other factors with managing a new ileostomy at home is that if it's persistently high and or the patient is not compliant or able to, for some reason, measure the output, they're not participating in that, then they may need, or sometimes if they just may need IV hydration no matter what, if it, depending on the length of the small bowel. So this can be coordinated outpatient. There's some patients the team has been talking about getting them established with an infusion center before they even go into surgery, because there's some patients we can predict that they will need IV hydration for various reasons, the compliance reason, their overall health status. And if we can get them set up with an infusion center ahead of time, that will save several hours of care coordination on my end and the medical assistants as we try to coordinate these in a more emergent setting, because we want to avoid sending the patient to the emergency room. Our emergency rooms are over full right now, and it would be not great care, of course, to send a patient to the emergency room for IV fluids, and also expensive for the patient, and it's expensive care to go to the emergency room for IV fluids. So it's possible to get the IV hydration set up urgently within a day or two, but it usually involves some begging and pleading with the infusion centers. And other times there's other things to consider with a new stoma, which our wonderful stoma nurse that you met with already went over a little bit. Sometimes the appliance isn't fitting right, the skin is getting irritated, they need more education on self-management, and all of these things, all of these reasons would be a very good reason to refer them back to our incredible stoma nurses who they already had been working with in the hospital. So they just may need more interventions from our stoma nurses. The last part of nursing management of benign diseases is symptom management. And we have a lot of patients with chronic conditions that could be, some of our rectal patients that are not ready for surgery yet, or surgery is not yet indicated. And so they call saying that they're having some kind of flare, whether it's an abscess or hemorrhoids. So we spend a lot of time triaging their symptoms, because patients in this population can have very high anxiety, so it can be difficult to discern the acuity, and that takes some extra time and attention, but we want to make sure that we are triaging those patients appropriately and getting emergent or urgent/emergent care for people that really need it, versus the patients that are having some anxiety around it and need some reassurance. We also collaborate, like I said, very closely with our GI and IBD department. The nurses, it's not uncommon for the nurses to have one of our shared patients that they're managing medically develop an abscess, and they need to see one of the surgeons urgently. And so that's pretty common. So we coordinate that. And then the anorectal disease flares, and then symptom management of postoperative calls is something that we cover a lot too. I wanted to review a case study of sorts for what my role looks like getting a patient from the clinic to surgery and back home, just to pull it all together. We had a patient, a pretty complicated patient recently, who needed a colectomy for diverticular disease. She had been to the emergency room many, many times, and surgery hadn't been recommended for her because of all of her comorbidities. I believe that she was diabetic. She may have had some cardiac issues. I believe she also has fibromyalgia and chronic pain. She lives in a rural setting, so some of the her barriers to care is she lives in a rural setting. She does not drive herself to appointments, so she needs to, and she didn't qualify for the state insurance that would provide transportation, so she would need to recruit a friend to drive her to appointments. She was also very sedentary because of her chronic pain. She had very poor nutrition because of all of the frequent flares. And so for a while, we were working on optimizing her, but her symptoms became severe and she needed surgery. So we worked on planning surgery. She needed ostomy marking, she needed nutrition support, and we needed to get her in for surgery. So we referred her locally for marking, and stoma marking and education. And that can be helpful because then they have established in the community a stoma nurse to help support their stoma needs after surgery. And I believe she also needed optimization from her primary doctor to make sure that she was cleared for surgery. She met with our anesthesia team to clear her for anesthesia. So we got everybody involved, we made a plan, and then had a time of low hospital staffing. And in those situations, we are required to reschedule non-emergent surgery. And this would qualify as a non-emergent surgery. So then we had to start not from scratch, but had to postpone it and manage symptoms in the meantime. So that required phone calls with her, checking in to make sure symptoms were still managed and not becoming emergent until surgery. Then she got into the OR, surgery went well. She was sent home with an ileostomy and had a difficult time managing her ileostomy. So there was more phone calls to work with the management of high output and avoided readmission for her, and then just continued to offer support. She's still healing from surgery, but that's a little picture of clinic to surgery to home. And lastly, the benefits of care coordination. Overall better outcomes for patient. The timing of their care is appropriate. Sometimes we will plan surgery for someone and their symptoms become more severe, so we need to move up surgery. So efficient and high quality coordination will make sure things progress on time. It allows for enhanced decision making for the physicians as we continue to collect data, whether that's a patient condition or collecting outside imaging or even imaging at our facility, and avoids unnecessary admission or readmission. So we do our best to optimize the care and avoid evaluation in the emergency room when it can be done in a clinic. There's obviously times when someone needs emergency care, and so directing them to that is appropriate, but if we can avoid it, we do. Patients are more satisfied when they know they have a person to connect with. The medical system is overwhelming. The medical terminology can be overwhelming. And patients are more satisfied when they have a relationship that's been fostered and nurtured, so that they know they have someone or a team that they can call with any questions regarding their care, and they feel more involved. So they're satisfied because they are an active participant in their care. And lastly, it's an efficient utilization of resources. Our operating room block time at the hospital is very limited because of staffing, and I'm sure it's the same here. So we work to make sure we have the right patients grouped on a day to fill the time and not have, you know, a chunk of time that goes unused and wasted. This is efficient, cost efficient for the organization. And then the patient sees cost efficiency because we've been able to bulk their appointments together and deliver affordable care, which means outpatient care, because of course inpatient care is so expensive. So those are the benefits of and how what the nursing management of benign disease is. Thank you. I just can't thank all of you enough for having me here, and it's such an honor to collaborate with the other nurses and the rest of the team. And so I really thank you for the invitation and for your time. So I don't know if there's any questions, but I'm